epidemic that was mostly Middle East, that's why it's called Middle East respiratory virus. The mortality was 34%. And this virus has a lot of neurological effects and neurological complications. And why it affects the nervous system? Because it binds to the ACE2 receptors. That's how it works. Now, most people think that ACE2 receptors are in lungs and upper respiratory tract, where actually they are. But a large number of ACE2 receptors are in the brain, especially in the hypothalamic region, in the frontal lobe. So it causes a lot of neurological problems. And it also, the receptors are in the gut, so it affects the nervous system of the gut. So you are going to see in this presentation that how in a huge domain, it affects the nervous system of the whole body, in peripheral nerves, central nerves, neuromuscular junction. And now from this COVID data, we had a lot of information about this involvement of the neurological system. How it causes nervous system involvement? So virus can reach to the brain from the spillage of the lungs. It can have direct access to the nervous system via circumventricular organisms. A lot of time it goes through the blood vessels. So ACE2 receptors are in the blood vessels. So it goes through the blood vessels and causes endothelialitis. And that's why you see a lot of neurovascular complications of this problem. And it also causes a hypercoagulable state. So this is why a coagulopathy may lead to vascular infarcts or even venous infarcts or thrombosis of the venous system. On top of that, it can also cause demyelination of the brain. So these are the possible mechanisms of injuries to the nervous system, and in some patients we have multiple mechanisms. So that's how it affects the nervous system. And now we have a lot of data related to neurological involvement in the previous epidemic and this new epidemic. In the previous epidemic, which have been well reported, so those patients with the SARS, they have meningoencephalitis, they have large vessel strokes, they have seizures, status epilepticus, they have peripheral neuropathies, myopathies, myositis, and their long-term neurological complications lasted for months and months. So we have data from SARS, 12 to 36 months follow-up, and a lot of people continue to have fatigue, myalgia, depression, REM sleep problems, hypothalamic pathology even after 2 to 3 years of this virus infection. And I think that lesson from the history is going to tell us that how we have to do or deal with this virus in future, especially 12 months or 24 months after the infection. Same thing happened with the MERS virus epidemic. About 1/3 patients who have MERS, they have neurological involvement, malaise, myalgia, demyelination. A lot of people have hemorrhagic necrotizing encephalopathy, periventricular white matter lesions, cerebellar involvement. So this is all present in the previous viruses. Now with this virus, now this is the data that about 8% to 34% patients who have SARS infection, this COVID-19 infection, they have neurological involvement. And a large number of survivors, now we are seeing now, which we label them as the people who have recovered from COVID infection. They actually have not completely recovered. They have survived, but they have not recovered. A lot of them, they do have neurological problems at this moment, and they are going to have a lot of neurological problems in future. So it may be up to 20 to 30% patients who have involvement of the nervous system at the time of infection, or even 6 months or 12 months after the infection. Most of this data is coming from Europe and China, which I'm going to present. But now we have local data, and that we will be publishing in future. We have started a lot of projects related to neurological involvement in COVID-19. Now this is the data which has been published, that what these patients have. So there's a lot of headache, agitation, delirium. About 22% patients present with impaired consciousness which come to the hospital. Anosmia and hyposmia, this is very common complaint, and even it precedes the infection. A lot of people think that this is a preceding symptom, that agar kisi ko smell khatam ho jaye ya taste khatam ho jaye and then they develop fever, then likely that you are dealing with COVID infection, because COVID goes to the olfactory bulbs. That's the first place where it resides, and it affects the taste buds. So there's a lot of involvement of the nervous system to start with. And A lot of loss of smell also is a problem. Then we have a number of patients who develop stroke. So stroke is a very common problem in patients. We are seeing here in our Pakistani population a large number of patients. They do complicate. In the previous studies coming from Europe, it's about 5%. It's about 6% or 8%. In some studies, about 1 to 2%. In some studies, about 20%. So stroke is a very important complication. Then you have frontotemporal hypoperfusion, and that translates into a lot of frontal lobe dysfunction. Arterial and venous thrombosis is a very common problem. That's why now a lot of people are giving these COVID patients empiric anticoagulation therapy with the newer anticoagulation agents. We do see patients with subarachnoid hemorrhage, acute hemorrhagic necrotizing encephalopathy. We have patients with meningoencephalitis, encephalopathy, a large number of patients present with seizures, and even myelitis, which is involvement of the spinal cord. So this is also a common presentation of COVID-19 patients. Other than this central nervous system involvement, there's a lot of peripheral nervous system involvement. So we have neuritic pain, we have reported patients of GBS, which is Guillain-Barré syndrome, Miller-Fisher syndrome, polyneuritis cranialis, or even a lot of patients who have only neurosensory hearing loss. So it can even affect the vestibular cochlear nerve. Myalgia is very common. 36% patients who have recovered from COVID-19 infection, they do complain of muscular pain and aches sometime most of the day or all day or large part of the day for many, many months. So this is a very common problem. Muscle fatigue is common. Myopathies, 10% patients develop frank myopathy. Rhabdomyolysis is common. And a lot of patients who have this neurological involvement, they have involvement of the respiratory systems. So we have seen patients who die of COVID who have no lung involvement, and they died of central respiratory failure. So they have involvement of the respiratory center in the medulla and brainstem, and they die of central respiratory failure. So this is also possible that you can have involvement of the nervous system, which is affecting the breathing and respiratory pattern. We have a number of isolated reports related to neurological involvement affecting spinal cord, myelitis. Myasthenia gravis is a problem of the neuromuscular junction. So you can have involvement of neuromuscular junction with COVID-19. Cerebral venous thrombosis is very common. We have the largest database of CVT related to COVID, which we are going to publish soon. Neurogenic respiratory failure without involvement of the lung is also well reported. So patients may have involvement of the brain stem, which may cause respiratory failure. Status epilepticus is also well reported. And now we are seeing patients with demyelination. So this virus not only causes infection to the brain, it causes an immune response which causes demyelination and immunological injury to the brain. So we are seeing patients with acute disseminated encephalomyelitis and periventricular lesions related to demyelination. A large number of data is related to neuroimaging. Most of these patients who have neurological involvement, they undergo CT scan or MRI of the brain. A lot of different abnormalities have been well reported in the literature. As you can see from these MRIs, that you can find the abnormality pretty well circumscribed and kind of involving most of the white matter and gray matter in the brain. So these are some of the selected MRIs of COVID-19 patients, and sometimes these complications persist even for longer period of time. And most of the time you are seeing that it's involving the frontal lobes and sometimes the white matter or deep white matter of the brain, and sometimes periventricular white matter. We have some data from the post-mortem findings, and these are the patients who did not survive, and even patients who did not have a lot of neurological symptoms when they were presented or they were admitted at the hospital. But the post-mortem findings have shown most of the patients have neurological involvement, especially when you do the brain pathology. So intracranial vasculopathy was present in majority of patients who even did not have neurological symptoms to start with. There were asymmetric olfactory bulbs, which means the olfactory bulbs were involved. Subcortical micro and macro bleeds were present in a large number of patients. Multifocal hemorrhagic lesions, press means posterior reversible encephalopathy, infarctions, and endothelial inflammation. So these are the things which can be present and can be picked up on pathology, but if you do early MRI, you can pick, or do MRI, you can pick up most of the things. This is some of the data we have published. So this is a paper we published in Lancet Neurology, COVID-19 International Neurological Registries. This is a paper we started where this is a very important publication which has many citations so far. That was published in Journal of Neurological Sciences, Journal of Pakistan. This is a study related to stroke. We started global stroke registry related to COVID, and this is a part of the JPMA special issue related to COVID-19. And our journal, Pakistan Journal of Neurological Sciences, have reported a lot of interesting phenomenon related to neurological involvement of this COVID-19 infection. So this COVID-19 infection is a very important neurological infection to us. It's a neurotropic virus, and we are doing research related to how this neurological infection has transformed the neurological care in this COVID-19 pandemic. We have done a national survey of COVID preparedness and impact of about 40 centers in Pakistan. We have already started a neurology registry. At AKU, we have about 1,200 patients with COVID. So we are analyzing the data. We have started a COVID stroke and cerebral venous thrombosis registry, which is a very important complication. And we are working on a national COVID neurology registry. And on top of that, I think the most important part of this neurological involvement is going to be the long-term outcome of this patient. So there are just two important messages: that patients who have survived, they have not recovered actually. A large number of these patients, they have problems with the neurological system, and they will have problem with the neurological system. So you have to keep an eye on those patients, and you have to go and see a doctor, especially behavioral problems and sleep problems and depression, and these kind of problems are going to be very common. And we are going to look at a long-term outcome of these patients, 12 to 36 months, especially the neuropsychiatric impact of COVID-19 infection. So hopefully we are going to learn a lot of new data related to neurological involvement of this COVID infection. And hopefully this will translate into new knowledge, new research, and some new remedies or strategies to take care of these patients in future. Thank you again, Dr. Rabia, and thank you all for listening. Thank you very much.